All right, well, greetings everyone. I apologize that I'm having to pre-record this, but unfortunately, with circumstances being what they are, the show must go on, and so I will be unavailable during the live time, but here you go. We will continue on. I encourage you, if you have questions, either post them up on the sticky board, to which I can respond to at the next class period and answer them then, or we can send me some emails and I'll try to collect those and then I'll be able to respond to them at class as well. I won't mention your names, of course, so it'll be anonymous, but I want to make sure that everyone has the ability to hear the answers to those questions you might have. Because again, this is new topics. These are new topics for you. This is a difficult set of concepts to get a handle on, so we'll get through it. But anyway, going forward, let's start talking about or continue talking about our antibiotics. If you recall, the last time we chatted, we were talking about our beta-lactam antibiotics. We talked about how they work on the cell wall in order to basically prevent the bacteria from completing those cross links between different layers within the cell wall that then cause a structural breakdown. The cell lyses open, and thus you have a bactericidal effect on the bacteria. So the way that those worked was by actually using that beta-lactam ring like we saw before, but now we're going to be switching gears and working with an antibiotic that does not work through the beta-lactam ring, but is still going to be cell wall active. And you're going to find that basically anything that has an effect on the cell wall, causing it to break down, is likely to have a bactericidal effect. And so starting off with vancomycin, this is certainly no exception to that rule here. And so you can see it's a pretty large molecule, which actually does have some impacts on how we use it and its volume of distribution and things of like that nature. But getting into the mechanism, you can see here this is called a glycopeptide antibiotic. I only mentioned that to delineate it that it's not a beta-lactam antibiotic. Really, the only ones that fit into that category that we mentioned were things like your penicillins, your cephalosporins, your monobactams, and your carbapenems. I apologize if I missed anything off that list, but those are the main ones that we talked about last time. Here, what we're going to see is that vancomycin works through a different mechanism. It doesn't actually work on the penicillin binding protein. If you recall, that was the protein that penicillins and all the other beta-lactams worked on in order to prevent the bacteria from completing that cell wall. Well, here instead, vancomycin actually will directly bind to those two D-alanines that beta-lactam ring actually tries to sort of mimic to that penicillin binding protein. Because it directly binds to it and prevents that structural integrity from being established in the bacterial cell wall, you still get a similar effect of the wall breaking down, the cell dying, but basically you tend to find that it is more difficult for the bacteria to develop resistance to vancomycin, which is why it is, for sure, if you've ever been in a hospital working there as an MA or scribe or whatever role you were in, you frequently saw that vancomycin was probably ordered on a lot of patients, and there's going to be a very good reason why that is, as we'll see here in a moment. Now, vancomycin itself is fairly specialized in what it works for. Even though we saw it being used all the time, or you will see it being used all the time, that is for a very specific purpose. This covers gram-positive bugs only. It doesn't get anaerobes. We'll talk about one notable exception to that. And it also does not cover gram-negatives. This is really only given for gram-positives. And the main gram-positive that we use this for is if you suspect a patient has MRSA, right? That methicillin-resistant Staph aureus. They're at a high risk for having MRSA, whatever type of infection it might be, whether it be a pneumonia, bacteremia, skin and soft tissue infection. If they are ill enough to have to come to the hospital, vancomycin is very likely to be used for that patient because it works very well for MRSA. Now, those things are changing. We'll mention that in just a little bit. Now, in some cases, you may also find that vancomycin has a role to play in patients who are penicillin allergic. So, for instance, if they had a really true blue anaphylactic allergy to penicillins and say cephalosporins, maybe they had a reaction to both, you tend to find that patients who have an allergy to one drug, they tend to predispose them to having reactions to other drugs as well. It just happens to be how their immune system reacts and tends to be a little hypersensitive. But what we see here is that if you had someone who is truly allergic, could not receive penicillin, cephalosporins for, say, for instance, surgery, this might be a really good alternative for that. Because when you have a patient who's going for surgery, let's say, for instance, an orthopedic procedure, where you're really only concerned about skin flora as being a causative microorganism to cause an infection post-op, you can use something like vancomycin that's going to be very good at covering all of those gram-positive bugs there, so that's great. Now, you will find that vancomycin is most frequently given IV. It actually has really terrible oral bioavailability. It's like 0%. So you'll never see oral vancomycin being used for a systemic infection. However, sometimes you still do see vancomycin being used orally, and you're like, well, why would we do that if it doesn't have any oral bioavailability? Well, the answer is because it depends on where the infection is, right? So in this case here, we see that actually you can use vancomycin for C. difficile infections orally, because where is that infection at? Well, it's actually in the intestines itself. It's in the colon and small intestine to some degree. So by using it orally, you're actually able to target just the GI tract, and it actually even has really no side effects from a systemic standpoint because it just doesn't get absorbed. So that's actually one of the interesting things you're seeing there. There's another drug we'll talk about later that is commonly used for C. diff, but it's actually due to resistance. Vancomycin is now becoming, especially for adults, more of the first-line agent. So you're going to see more of that being used certainly in the future. Other things we're going to be using this for include things like endocarditis and osteomyelitis, things where gram-positive bugs, and including MRSA, are more likely to be found and be the causative organism there, so you'll see it used a lot for that. And I already mentioned the surgical prophylaxis potentially. One interesting use I've actually seen with some of my orthopedic surgeons is that sometimes when they're doing certain spinal fusion procedures, or they're doing some kind of bone graft or something like that, there's a paste that they actually use. It's almost like a cement that they're using for part of that fusion, and they can actually mix in vancomycin powder along with that cement, and as they put it onto the patient and it hardens, it's actually kind of neat because it kind of leaches out small amounts of vancomycin right there at the site, preventing infection from happening. So kind of a one-off case there. I won't ask you a test question on that, but it's kind of good to be aware of some of these different sort of unique uses for the drug. I know I'm talking a lot about vancomycin, but that's because it is so important, because you're going to use it quite frequently, especially if you're dealing with patients who are infected with all kinds of organisms, where maybe you're not really sure what they have, and you got to think about MRSA, right? So if you're dealing with say a pneumonia in an elderly patient who's coming from the nursing home, right? Or if you have someone who is immunosuppressed due to cancer treatment or things like of that nature, you're going to see vancomycin being used pretty frequently. Now, one of the things that we're seeing though is that with overuse of the drug, you tend to see that resistance does develop to it, specifically with Staph aureus. That's why if you ever hear the term VRSA or VRSA, that's vancomycin resistant Staph aureus, and that's where basically it's become resistant enough to where the vancomycin is unlikely to eradicate that infection with standard concentrations, right? And so what we're going to find is that as the MIC for the bacteria sort of increases, you'll tend to find that it's more difficult to get levels sufficient enough to actually end up treating that infection, right? So as an example, we talked about how the beta-lactam antibiotics were time-dependent killers. Remember that we need to keep their levels above the MIC for as long as possible, because once it drops below that, you can then see the bacteria start to reproduce and start to replicate again. Here, vancomycin is no different. It's a time-dependent antibiotic, meaning it needs to be above that MIC, which is why we look at the MIC so much. And this is actually going to be the first example of a drug that we frequently do therapeutic drug monitoring on, meaning we will perform or acquire plasma levels from patients in order to see sort of what their levels are like. And here, we don't really care what the peak level is so much, because it's not a concentration-dependent killer. More so, we care about the trough. So if you ever hear about getting a vancomycin trough level, that's what I'm referring to. Making sure that the trough level is above that MIC to a sufficient level such that it's able to eradicate and kill off that infection there, right? And so you can see how we can dose this a few different ways. I'm not going to quiz you on dosing specifically, but one of the things you can see here is we can actually shoot for different trough levels for the drug depending on what our indication is, which is kind of interesting. So for instance, if you have a patient who has an infection at a site that's relatively easy to get to, right? So say for instance they have a bloodstream infection, right? Well, vancomycin is frequently and most commonly given IV. That's the drug going right into the blood where you're presuming the bacteria are. That sounds like it's pretty easy to get to that site. So we can actually shoot for maybe a trough of 10 to 15 micrograms per ml. Now, what if we have a more difficult site to achieve sufficient concentrations at? Because remember, we're checking a blood level. That is a surrogate for what the level is going to be at in the actual tissues where the infection is. If we're treating a patient with meningitis, we don't check CSF levels of vancomycin. We still check blood levels and use that to correlate to what we presume the levels would be at in the CSF. So in the cases we have more difficult to penetrate areas like the lungs, like the CNS, places like that, that's where we end up shooting for higher trough levels, something like 15 to 20, for instance. And so just know that that can change depending on the indication, and frequently there's a lot of policies put into place, whatever organization you're working for, to help guide you to make sure you're making sort of the best choices about what kind of trough levels you want to look for, right? And so, again, as those MICs start to raise up, you're going to see that it's more and more difficult to achieve concentrations sufficient to kill off the MRSA. And you're thinking, well, why can't you just give a bigger dose? Just keep giving a bigger dose until you get above that MIC. Well, that's where we're predisposing the patient to toxicity, and vancomycin is not a harmless medication, as we're going to see here in a minute. So that's why after a while, if you see the MIC start to rise up, to too high of a level, you're going to start to see that maybe we need to then switch over to alternative therapy. That's where we start to get into that VRSA sort of territory. We're thinking vancomycin resistant Staph aureus. And I'll show you a few examples of that. Problem though is we don't have a ton of alternatives, right? So there's not a whole lot of backup drugs we have to use once vancomycin is not going to be sufficient. So one of the big things, and again, I see practitioners do this incorrectly all the time, is you got to focus on getting that drug to steady state prior to checking your levels. And remember, we're checking trough levels here for vancomycin, specifically because it's a time-dependent killer. We want to make sure that it's above that MIC there. And so what you tend to find is that practitioners, either new or experienced, I've seen both make the same mistake here, is that you'll be dosing the medications. So you see the levels start to rise, and as that level drops off, then you give your next dose, right? So that trough level here is what you're measuring. And then they give another dose and it drops off. So it takes like roughly 3 to 4 doses before you're really at steady state for this particular drug based off of its half-life. And if you recall, it takes roughly 4 to 5 half-lives for a drug to get to steady state, right? So in these cases here, what you want to do is make sure you're checking the trough around before that 3rd or 4th dose in order to make sure you're at steady state. What happens if I check it before the 2nd dose? Well, you notice here it looks like the level is too low. So what am I going to do as a result of that? Well, the level looks low, so I'm going to go ahead and just increase it. I'm going to either increase the dose, or I'm going to give it, instead of every 12 hours, I'm going to give it every 8 hours, for instance. And that's going to be a problem because now you're giving a new regimen. Once you get up to that new steady state, it's going to be too high. And that's what's going to predispose us to some particular toxicities that we're going to see with vancomycin. So really want to make sure you get to steady state. Now, what could you do to get around this? Well, could you give a loading dose? Yeah, sometimes we do that, especially if we have a particularly sick patient. You can actually give a loading dose early as the first dose in order to get them to steady state earlier, and then we can check our levels, sometime after that. So, but usually we still wait till the 3rd or 4th dose to kind of see what the patient's going to do. Because again, just very similar to the grand majority of the beta-lactam antibiotics we looked at, this is also going to be renally eliminated. So you really got to watch renal function, because with your more sick and labile patients, their renal function can change from day to day, from hour to hour in some instances. And so you got to be able to respond to that with the changes in medications necessary to prevent them from becoming toxic, right? So looking here, just to give you some examples of some of the dosing regimens we might use. Again, I'm not going to quiz you specifically on doses. I'm just letting you know how we're using these drugs and why we might use something like a loading dose, or why we might dose it differently in terms of the frequency that we're giving the drug, right? So if you recall here, the loading dose we can give to get to steady state a little bit sooner, and then, the typical doses that we would end up using. Keep in mind when you're dosing stuff like this, if you were to have, say, a prescription assignment where you needed to write a prescription for a medication like this, typically things can be rounded, especially for adult patients. So for instance here, most vancomycin doses are going to be rounded to the nearest like 500 milligrams, Maybe, 1250 is given sometimes, but for the most part, those are going to be sort of your increments. If you write down, please give 974 milligrams of vancomycin, we're just going to give them a gram, right? The only instances where that might not be the case is typically in pediatrics, where we do want to be a little more specific, right? Anyway, so there's the typical dosing you'd use, but remember, the dose is important, but the interval is also important. And so we actually will base this off of the patient's renal function. If you recall, typical renal function in terms of creatinine clearance being somewhere between like 100 and 120 mLs per minute, maybe a little lower, maybe a little higher, depending on the patient. And so in those cases there, we can see that depending on what the patient's creatinine clearance is, and if you recall, for most adult patients, we're going to be doing this based off of the Cockcroft-Gault equation. Probably the most common one you're going to run into for adults. You can see here, okay, we're going to give it Q8 hours. Okay, so maybe you're giving a gram Q8 hours for someone who has pretty decent renal function. Whereas once that starts to drop down, notice here that we're giving it less frequently. Now every 12 hours if they're between 50 and 70. Now give every 24 hours if they're 30 to 49 mLs a minute, or if they're on continuous renal replacement therapy. That's a form of hemodialysis that we'll talk about more in the renal section when we get into Pharm 2 next semester here. And then sometimes what we'll actually even do, depending on what's going on, if they're unstable or if they're achieving or they're utilizing intermittent hemodialysis, sometimes we'll just give a single dose, because we know if the patient's renal function is pretty poor, they're not going to get rid of it. It's going to just stick around there because it doesn't really get metabolized much in the body. It's only renally eliminated. So sometimes we'll just give a dose and they'll wait around, and maybe 48 hours later we'll check a level, right? Or maybe 24 hours later, whatever the case may be. You check a level, see what the trough is. If it's still high, then okay, they still have enough sticking around where I know it's still above the MIC. I don't need to redose it at this point. And then you keep checking. Once it gets down either close to or below your therapeutic trough, then you go ahead and redose them. That's called random levels, intermittent dosing. That's how we would typically sort of talk about that. So again, don't memorize these intervals based off of the renal function. I just want to show you how we're changing our dosing to account for changes in renal function. And it's not just the dose you can change, it's frequently the frequency is what you're going to be changing here, right? Because we need the dose in order to get to reach a certain level such that the troughs are not going to be too low. But again, by changing the interval, we're giving the body more or less time to get rid of that drug prior to the next dose being given there. And that has a huge effect on what the steady state levels are going to be like. Okay, so as I mentioned, in terms of monitoring, you got to look for renal clearance. If the levels are too high and the patient starts to accumulate the drug, that's where we start to worry about some issues. And in particular, you want to note if a drug has very sort of unique side effects or unique toxicities, because those are pretty good test questions. And I also would ask about them because I think they're important to know from a clinical standpoint. You got to know what to look for to know if your patients are having any issues with the medications you're giving them. And so two of the big ones being for vancomycin being ototoxicity and then nephrotoxicity, right? I already mentioned renal function is really important for vancomycin being cleared in the first place. The ototoxicity is kind of interesting because as the levels start to accumulate, you can actually get levels high enough in the hair cells in the cochlea that actually damage them and can lead to hearing loss, which in some cases is permanent. Now, that's going to be difficult to determine if you have a patient who's in the ICU, they're intubated, they're being sedated, and they're getting vancomycin for a pneumonia or something like that, right? To where you're not going to be able to say, hey, can you hear? How's your hearing doing? It's not so simple because the patient is unconscious, right? So by looking at those levels and making sure that your troughs are not too high, you can pretty well mitigate that risk for developing ototoxicity in that patient. Another interesting, or not interesting necessarily, but one thing to note with the nephrotoxicity is that, remember, these might be patients who have pretty labile hemodynamic statuses, right? You may find that their renal function is changing from day to day, and if a patient becomes hypotensive, the body tends to not want to perfuse certain organs as much as it does others, right? There's preferential blood flow when a patient becomes hemodynamic because there are two main organs you need to stay alive. You need your heart and you need your head, right? So if I have a patient who is hemodynamically unstable and their blood pressure is dipping down into, say, the 60s over 30s, the GI tract is not the main priority. The kidneys are not the main priority. You want to keep that volume anyway. You don't want to be filtering anything because you need that blood volume to get as much pressure as you can. So what you tend to find is that when you start to decrease the amount of blood flow going to the kidneys, that further causes injury because the kidneys do require quite a bit of oxygen in order to maintain their activity, pretty metabolically active. If you start to underperfuse those kidneys, now all of a sudden the renal function has gone down, your GFR is down, and you're further damaging the kidneys. Now, add on top of that medications that can also cause nephrotoxicity, especially if the levels are too high. Now you have sort of a double whammy. And in a lot of cases, we're giving multiple drugs that could also affect the kidneys themselves. So you can see how it's a bit of a double-edged sword here. And you got to really monitor for this stuff. And not just look at the creatinine clearance, because it takes time for that to sort of equilibrate when a patient's renal function changes. Certainly, you're going to be looking at that, but also look at things like urine output. Urine output could also be a more immediate way to tell if a patient's actually producing urine or not. And if they're not producing urine, then they're probably because they're not filtering anything, right? So little things to note with that. When it comes to infusion-related reactions, this is another unique thing with vancomycin. This is something you definitely want to know about because this is a frequent pimping point you will get when on rotation. So red man syndrome, I know that sounds probably a bit outdated, maybe a bit culturally insensitive, but it is descriptive for what happens. If you take vancomycin, and what's kind of interesting, and I think I have a picture of this next up here, of a patient with red man syndrome, this is typically related to infusing vancomycin too quickly. So, you think about, giving a medication IV, you might assume everything is just IV push. You just push it into the patient, you're good to go. Many drugs cannot be given via IV push for a variety of reasons, whether it be causing thrombophlebitis, whether it be causing an infusion reaction such as this. So an important portion of the order that you would be writing as a clinician for vancomycin includes how long to infuse the drug over. In this case here, we frequently infuse vancomycin over 2 hours. It's a long time to be infusing a drug over in the grand scheme of things, and so we do that though because we want to mitigate this sort of reaction we're seeing here. Patients will feel very hot, they get very itchy, they look like they're having an allergic reaction. Important to note though, this is not an allergic reaction. This is an infusion-related reaction. Now, this used to be much more common because of vancomycin used to be much less pure in terms of how it was made. And you can see here this kind of dark sort of color of early vancomycin when it was being produced, and even later on when it was a commercial product, not looking great as compared to sort of the nice, pure, white sort of powder that it is nowadays. And actually had the nickname Mississippi Mud. So I don't know about you, but if I was in the hospital and someone came to me with a dark brown bag with maybe some particulate matter floating in it, I would not be super comfortable, especially if they called it Mississippi Mud, for that drug to go into my body. But it's gotten better, right? And so in some cases we can pre-treat with that, and we'll talk about anaphylaxis treatment later on, but we can use some of the similar drugs. So we can use things like antihistamines and antipyretics like Tylenol as well to help out with some of that. But just know, don't infuse vancomycin too quickly. Typically like 2 hours is what we're going to be infusing that over to prevent that from occurring, okay? As I mentioned, we're going to do a lot of therapeutic drug monitoring with vancomycin to make sure that we are getting levels high enough to be effective, but not so high that we're going to be causing a lot of this toxicity, as I mentioned previously, right? I mentioned getting the levels prior to the 3rd or 4th dose. Note that we're getting trough levels. We don't really care about peaks for time-dependent antibiotic. We'll talk about an example of that later where concentration-dependent antibiotics, we do care about the peaks. Right now, we care about the troughs for this particular drug, okay? Those are the main points I want to hit on that. So anyway, so the next thing I want to talk about is we're going to change targets a little bit. We're going to be switching from the cell wall, and instead what we're going to focus on is protein synthesis. And so basically what we're going to see here with bacteria is that our antibiotics tend to be pretty selective for the bacteria specifically, and the reason for that is because they have different targets than we do. Like, so for instance, penicillin doesn't necessarily have a lot of toxicity on human cells because we don't produce penicillin binding proteins, right? Similarly, you're going to find that when targeting protein synthesis in bacterial cells, we're going to be targeting bacterial targets as opposed to mammalian targets. And in this case here, in order to prevent protein synthesis from occurring, what do we affect? Well, we got to affect the ribosomes, right? We got to affect the ribosomes are actually going to be forming the DNA during the translation period, right? So that you've transcribed the DNA into RNA, and now we're going to translate it into actual proteins. And so this is where many of our antibiotics are going to come into play and actually inhibit this process here, okay? Now, do I care that you know the difference between a 50S binder or a 30S ribosome binder? No, I don't. I don't care that you know that. I am simply delineating it here just so you know there may be different targets, but they're still working on the ribosomes, and they're still inhibiting protein synthesis in a similar fashion. That's what I want you to know. In terms of the mechanism, that's how deep I want you to get into that. Here you're going to see some of the different classes that we're going to be talking about as we get into these specific ones here. Now, the first one will be the macrolides that we're going to be talking about. Now, it was pretty easy in previous drug classes to tell if a drug's a penicillin. Penicillin, amoxicillin, piperacillin, they all ended with cillin. It's pretty easy to tell if a drug's a cillin or not. And that's a great way to memorize drug classes, is to look at the naming conventions and see how they are organized. That's all well and good. You're going to find, that for the cephalosporin, it's pretty easy. Ceftriaxone, cefepime, they all started with a ceph prefix. This is where it gets a little more complicated, and this is where you might need to dedicate a little more mind space in order to delineating these different drug classes in your mind to make sure that you have them straight. So for instance, when I talk about azithromycin and for example, gentamicin, right? So azithromycin and gentamicin come from two different classes, even though they kind of have the same suffix there. So it gets to be a little more complicated for some of these drug classes that don't have nice and neat sort of naming conventions, but just to let you know, start to kind of think about that in your head too, to start to compartmentalize these into neater sort of categories. Anyway, getting into talking about the macrolides specifically, they're going to be working on that 50S subunit of the ribosome and blocking protein synthesis, okay, basically preventing that transpeptidation occur with some of that transfer RNA. Note here that in general, you're going to find that, and you can imagine this too, if a bacteria, or if you, for instance, if you stop producing proteins all of a sudden, would you die off immediately? Well, probably not, because you still have a lot of proteins around, floating around doing their own thing. It probably would not be comfortable, but it would probably be something you could survive for a period of time, right? Now, similar to bacteria, you're going to find that the same thing happens here. So these protein synthesis inhibitors tend to be bacteriostatic. You recall we talked about bactericidal drugs, we talked about bacteriostatic drugs. These tend to be more on the bacteriostatic sort of thing. So these do require that the patient's own immune system be functional enough that it can come along and also help out the drugs to eradicate that infection. Okay, so one kind of useful thing to note between these more bactericidal drugs versus bacteriostatic is that these do require a little bit of extra help from the host immune system as well. So it may not be as good to use in someone, say for instance, that they have a poor immune system, either due to disease, due to genetics, due to whatever particular reason it happens to be, okay? Anyway, so getting into the specific macrolides, we have erythromycin, which comes as a variety of different dosage forms. We'll talk about erythromycin later on in the derm section. We talk about treatment for acne, for instance, but we also have some oral and some IV options available as well. Notice here that sometimes drugs will come in different salt formations, and that can have an effect on what sort of dosing you're using, what sort of, whether it's extended release or not, and things like that. So for instance, you may see erythromycin EES, that stands for erythromycin ethyl succinate. You may see a stearate salt, so there's some differences there. And you'll notice that when you're looking up the drug dosing, you can see kind of what how that may change depending on the salt that you're dealing with, right? Other than that, we have clarithromycin and then azithromycin. Those are going to be the three main macrolide antibiotics we're going to be dealing with. Clarithromycin, azithromycin, I probably see more commonly being used for anti-infective purposes. Erythromycin has a little bit more specialized use, especially in pediatrics, as we're going to see in just a few minutes here. All right, so the macrolides tend to actually be pretty broad spectrum. They actually have a really kind of nice spectrum of activity, which is why they tend to get overused in a lot of cases here. So as you can see on our little street light of antibiotic coverage, you can see here that it doesn't provide much anaerobic coverage. So you don't see it used for a lot of gut stuff, a lot of anaerobic infections. However, they do provide pretty broad gram-negative and gram-positive coverage. What's also handy is that they also tend to cover a lot of atypical pathogens. Okay, so that'll be important for why we use them just a little bit, and you're probably hearing about this a lot in your ENT section as well. So looking at the gram-positive, it covers strep pneumo, MSSA, Listeria, a lot of good coverage there. No enterococci, so again, probably not going to be good for a lot of GI tract sort of infections there. From a gram-negative side, you're going to see H. influenza, Marxella catarrhalis, Neisseria, a lot of good coverage there, right? Doesn't cover a lot of like other typical gram-negatives, things like, E. coli or, Proteus and, things like that. So you probably wouldn't see this being used for like a UTI, for instance, but I'll talk about where its main uses are going to be in just a few moments here. And then the atypicals. This is really a big deal for this set of drugs here because they cover Legionella, Mycoplasma, Chlamydia, all the sorts of things there. So what does this look really good for? Well, if you go in through your ENT lectures, you're going to see, oh, look, there's strep pneumo, there's H. influenza, Marxella catarrhalis, and there's Mycoplasma pneumonia. That's like the majority of your upper respiratory tract and a lot of your lower respiratory tract infections. That's your bacterial sinusitis, that's your otitis medias, that's your a lot of your community-acquired pneumonias tend to be coming from this sort of four groups of bacteria here. And so because of that, macrolides are really good for respiratory tract infections and such that they're actually overused in a lot of cases because they're so easy to use and they do provide broad coverage. So you're going to see this being one where patients are frequently given Z-Paks even though they likely have a viral infection, because it's just easier to make the patient happy and get them out of your office and get the next person in. But you're not going to be that sort of PA. You guys are going to be better than that, because I'm not going to let you graduate unless you are better than that, right? Absolutely. Anywho, so looking at the different uses here, and again, am I going to ask you specific uses on from this section? Not necessarily, but when we get into ENT later on, yes, absolutely you need to know what these are going to be used for. But you can see here, respiratory tract is a huge one. You can get away with some skin and soft tissue infections because it does cover MSSA and some other gram-positives there. And we also, interestingly, use this for some atypical pathogens that are causing disease states that normally competent individuals don't have to worry about. So for instance, like Mycobacterium avium complex, that is something that patients don't get unless they have a really poor immune system. For instance, if you have more progressive HIV to the point to where your CD4 count is like below 100 or 50, that's where you got to start to worry about some of these bacteria that most immunocompetent people just don't get. And so we can use things like azithromycin for prophylaxis or treatment of pneumonia as an example there. Sometimes we'll give it some other drugs additionally. Chlamydia is another really big one you're going to be seeing azithromycin being used for if you're working in the ERs, the urgent cares. You know, someone has had a high-risk sexual encounter and maybe they've had chlamydia now, or they're at high risk for it, something like that. This is where azithromycin can also be pretty useful. And I said, you know, we don't use a lot of macrolides for GI tract stuff, but what's interesting is that with H. pylori, which is a pretty big cause for causing peptic ulcers, we actually do use the macrolides because it does have pretty good activity against that. So you might see clarithromycin, azithromycin being used for that purpose as well. So a lot of uses for the macrolides, pretty high volume antibiotic when you see being used in your clinical practice. Now, what are some issues with the macrolides? So certainly GI complications, nausea, vomiting, diarrhea. Guess what? Every single drug does that, right? However, you can tend to see that the GI effects are a little bit more consistent with the macrolides, specifically erythromycin more commonly. You're going to see that not only is it because it's disrupting normal gut flora, leading to some diarrhea and things like that, it actually also stimulates the motilin receptors. Motilin receptors are in the GI tract and they stimulate, guess what, motility, stimulate peristalsis. And so you can see cramping and diarrhea associated with that. However, I use erythromycin all the time in pediatrics for patients that do have peristalsis issues. Sometimes if they have gastroparesis and things like that, we can utilize the macrolides in order to help kind of stimulate and move things along. So using a drug side effect for therapeutic purposes, right? So a really good thing that we can do there. Allergic reactions are not super common, but are something to watch out for. You can see some cholestatic hepatitis, again, not common, but something you want to look out for. And then transient hearing loss. This is kind of interesting and not something you'll see commonly because it's more associated with like kind of large IV doses of these drugs. But by far and away, you're going to be using the macrolides orally. It's very rare that you see them ever being used IV unless you have a very specific need for this. Now, this is another big one I'm going to be talking about here that you'll hear. When you hear this pop up in future drugs, you want to think about this because it's a common thing that can occur. You know, rarely is it going to be something that's clinically detrimental to your patient, but you got to think about it, right? And I'll talk about this as QT prolongation and torsades de pointes, or just torsade de pois if you wanted to be a little bit more fancy and pronounce it like the French do. But what we're going to see here is that QT prolongation can occur with many different drugs. You probably have heard of this before, is QT prolongation causing torsades. You got to keep it in the back of your mind whenever using some of these drugs. Alone, these drugs are probably not going to cause your patient to go into torsades. If they did with any frequency, they probably wouldn't be used clinically because that'd be a very dangerous drug. However, what we're going to see is that when you start to combine these drugs together, or if you have someone who is predisposed to torsades due to electrolyte abnormalities, say they're hypomagnesiemic, they're hypocalcemic, they're hyperkalemic, if they have a congenital prolonged QT, this is where it can become more dangerous. Or if they're on other medications, as I mentioned, they also prolong the QT. So things like certain antiarrhythmics are going to be big ones, but certain antidepressants, certain antipsychotic drugs, there's a ton of drugs, anti-nausea drugs, they can lead to QT prolongation. When you start to combine them together, that's where their risk is going to go up, right? So why do we care about QT prolongation? What happens here? Well, it's kind of interesting is that these drugs all share a similar kind of pathology here in terms of how it prolongs QT, because it actually blocks potassium efflux, okay? When you get into cardio, and I'm sure you might have already learned this in your physiology class already, you need to know the cardiac cycle. You need to learn kind of the flow of ions in and out of the heart in order to allow for the normal sort of cardiac cycle to occur, right? And one of the big ones that we need to worry about is actually the repolarization phase, especially in the ventricles. So if you look, you have your QRS, which is going to be your ventricular depolarization, but the T wave, that repolarization, that's the really important thing that these drugs are affecting. So how does that repolarization occur? Well, it happens by effluxing potassium out of the cell. So you're taking positive ions out of the cardiac cell, and that leads to the electric potential of the cell to drop down, right, to repolarize, to get back to that resting membrane potential, so you can have another heartbeat come along. So what happens here is when you block this, it prolongs the QT, so this is normal, so the interval between the Q wave here to the T wave is now prolonged here. Notice here it takes a lot longer for those ventricular cells to repolarize. So what does that matter? Well, when you start to do that, you start to affect the refractory period of those cells, and you lead it to be more likely that a reentrant arrhythmia can occur here. And this is where you get torsades, which is this very characteristic sort of turning of the points, which you can see here. So you'll see it gets kind of very large in potential, and then it drops back down and gets very large. So it's almost like the peaks are flipping, and that's where you get that term torsades de pointes. So twisting of the points there. And so this is a very characteristic thing. This is something that is, you know, when you see it, you got to know how to treat it. We'll talk about that in ACLS later on, but it's magnesium. Magnesium sulfate is the treatment of choice for torsades. It's a good thing to get in your mind now because it'll come up over and over again. Okay. Other things too, you know, to know what a normal QTC is for a patient, right? It's QTC, right? The corrected based off of the heart rate of the patient, you know, is typically, you know, 460 to 480, somewhere in there, depending on the patient. When you start to worry about torsades, you're starting to get up in the 500 range. So you're talking about like, you know, 540s, 560s. I've even seen up into the 600s. That's where you're really starting to worry about that. I recently had a patient, I was on call for the poison center, and I got a call in, and there was a patient who was taking like 20 some odd tabs of Imodium. It's actually an anti-diarrheal drug that they were taking in order to prevent opioid withdrawals. And they came in and their QTC was like in the 560s. And so it's like, wow, okay, that's something we really got to watch for, because that's not normal for a patient. We don't know what our old EKGs look like. So we end up having to admit and actually watch for that to make sure they didn't develop torsades, make sure she's in the area of the hospital where they can go and they can monitor for her heart rate 24 hours a day, monitor her rhythm, and be able to use magnesium if she were to in fact develop torsades. So again, it's a real thing that happens, especially when you start to combine a lot of these drugs together. So you got to be cognizant of that and watch out for it. I'm only harping on it right now because this will come up again and again, and I don't have to repeat myself so much. Although I do like to hear myself talk, I don't like to repeat myself necessarily. So anyway, another huge thing to worry about here is also going to be the CYP drug interactions. Now, this is going to be most prominent with erythromycin, followed secondary by clarithromycin, and then azithromycin. Azithromycin being the least likely. but still can occur, right? So we're going to find that in general, you're going to see that the macrolides will inhibit the CYP3A subclass of enzymes, and which is the most important one out of all the CYP enzymes, 3A4, right? So because it metabolizes so many different drugs, you got to be watchful for that. So what is that going to do? If it inhibits CYP3A4, what does that do to other drugs that are metabolized by that same enzyme? Well, the levels are going to rise, right? Because I'm not metabolizing them as well, because my enzymes have been inhibited. So a lot of different drugs levels can be raised up, leading to more toxicity potentially, right? So you got to check the profile prior to prescribing. Make sure the patient does not have anything on board already that could be interacting with the macrolides that you would like to use in that patient now, okay? So get a full medical history. Make sure there's no medications going to interact here, because that could be a big problem for them. All right, up next we have the tetracyclines. You can tell they're tetracyclines because if you can count 1, 2, 3, 4 tetracyclines. So looking at this, we're going to see the main ones we're going to deal with include tetracycline, doxycycline, and then minocycline. These also work through blocking the ribosome here from producing new proteins within the bacteria, so preventing that translation from happening there. It's at a different site, but we don't really care about memorizing which site it is. Just know that it's inhibiting the protein from being produced. These are also going to be bacteriostatic, just like our macrolides, and these are also quite broad spectrum. And you're going to see that the tetracyclines, they look like they work for everything, right? Green lights all the way down. That's the first set of drugs we've seen so far that actually has that. And so you can see these are used frequently orally, so like tetracycline, minocycline, used orally. Doxycycline occasionally will come IV, right? So if you ever see, wiener dog on a bicycle, that is also a form of doxycycline, so go figure. Anyway, what does this cover? Well, it has really good coverage against atypical bacteria. So like we saw previously with like chlamydia and mycoplasma, it's going to cover that stuff. It also is pretty good at covering a lot of animal-borne organisms, right? So if you ever have like Yersinia pestis, what is that? Well, that's the bubonic plague. If you ever run into things like Borrelia, or if you ever run into Rickettsia, Brucella, all those different animal-borne organisms are going to be treated with probably a tetracycline. So the good coverage for that. It actually does have some MRSA coverage, covers Enterococcus, covers a lot of that good stuff, does have anaerobic coverage, can even treat syphilis here. You have the Treponema pallidum, lots of good coverage here. Not so much in terms of its coverage for like Pseudomonas or C. diff, but it covers a lot of things. And so you're like, well, why don't we use this for everything, right? It's got to be great for all those things. And it's pretty good, but we're going to find that there are some negative sides to it and some reasons why we can't use it all the time. Sometimes it's due to resistance, but sometimes due to some other things too. But what do we typically use these for? Well, acne is a big one. So you see a lot of like tetracycline, minocycline, either used topically or used orally. Pretty good for treating different types of acne there. Sometimes for atypical pneumonias, because it does provide good coverage there, and a lot of animal-borne diseases, so Lyme disease, Rocky Mountain spotted fever, definitely. And then in terms of like sexually transmitted infections, that should be an I and not a D there. Chlamydia can be covered with something like doxycycline. You're going to see, though, that when we talk about sexually transmitted infections, you typically like drugs that have sort of a one-and-done sort of dosing regimen. So, for instance, if I can give you a shot of ceftriaxone in the rear end and give you a one-time dose of azithromycin to treat gonorrhea and chlamydia, that's great because compliance is ensured. Versus if I have to give you like a 7-day regimen of doxycycline, I can't assure that the patient's going to take all 7 days of that. So there's some drawbacks to it from that standpoint, but it still can be an alternative. Now, what are some of the downsides of using the tetracyclines? They love to chelate with certain cations. When I say chelate, what does that really mean? Well, it means it likes to bind onto them, right? So that means if I were to take a tetracycline along with a calcium-containing product like milk, or if I were to take it with iron or something like that, they bind together and it prevents the tetracycline from being absorbed. That's not great because now your bioavailability is shot and you're not going to be able to treat that infection. Okay, so that's the downside. That also leads to some of the other side effects you can see once doxycycline or the other tetracyclines get systemic, right? So this means you can have things like discoloration of the teeth, right? So you see a doxy especially tends to be worse for this. And so this is where it makes sense that it can discolor the teeth, because what's in the teeth in great amounts? Well, there's calcium, right? So it can actually bind to that and lead to discoloration. And so we frequently avoid it in kids less than 8 years of age because they still don't have their adult teeth coming in yet, and that can affect those. But remember that this is more for like kind of long-term use. So we probably would use this for, if it was like a 5-7 day course of doxycycline, I wouldn't worry about the kids' teeth turning yellow or brown on you. But if they were taking it for a longer period of time for some reason, that's where I would start to be a little concerned and probably avoid it, right? The other concern, though, is if you had someone who was pregnant and was actually having, they're kind of growing a skeleton inside of them, which is kind of a weird way to think about pregnancy, but that's true, is it can actually affect the skeletal growth for the fetus as well. So we actually avoid it during second and third trimester pregnancy because there's some risk for actually binding to the bones there as they're developing and can lead to issues. So I would say that's contraindicated in those later stages of pregnancy, right? And they have to be renally dose adjusted, so similar to a lot of the other things. Note that the macrolides did not require any renal dose adjustments. That's another big benefit for why people like things like Z-Paks, because you don't have to think about things like the renal function. Okay, so up next is a drug that is sort of similar to the tetracyclines, as you can see here with the structural similarity, the 4-ring structure here. Here's one called Tigacycline or Tigasil. This is one of my favorite drugs for a variety of reasons. One, you can see Tigasil, you think tiger. It actually comes as a nice orange sort of coloration here, and even all the marketing. You can see a tiger. I mean, imagine if you were the provider walking down the hallway with a tiger at your side. I don't think you'd have any pharmacist telling you, no, you can't have that drug. Because you're just that cool. But also, if you look at the chemical structure, it kind of looks like a tiger a little bit. You have like little legs here, you have the little tail coming off of it. So I think if you use your imagination, which I don't have much of left anyway, but I can kind of see a little bit of a tiger structure to this, which I think is pretty cool, especially if you're into Joe Exotic or any of those shenanigans. Anyway, getting back into tigacycline, note here this has the same mechanism as the other protein synthesis inhibitors we've seen so far. Bacteriostatic, so again, not great if a patient really needs that extra sort of bactericidal effect, like if they have a poor functioning immune system, for instance. But this one's kind of interesting because it does cover a pretty wide variety of things. So similar to the tetracyclines, you see it's green all the way down here, and actually we can use this for some really nasty resistant bacteria, right? So if we had something like E. faecalis here that was resistant to a lot of drugs, we can use it for that. We can use it for MRSA. We can actually use it for a lot of other type of complicated intra-abdominal infections, because it does have good anaerobic coverage and will cover gram negatives. So pretty good coverage in terms of this, but we do like to hold off on using it too frequently because this is sort of a backup drug that we like to hold on to because of once it gets resistant to this, again, there might be few options that we can transfer over to. So we like to hold on to this drug as long as we can, but it's a kind of like a beefed up version of a typical tetracycline, right? But I kind of break it off into its own little category here. Again, from a side effect profile, not a ton of stuff here, as you can see. No CYP interactions we really want to worry about, no chelation reactions. Really the big thing to worry about is if they have pretty deficient hepatic dysfunction, or pretty significant hepatic dysfunction. That's something you might want to watch out for. Okay. So up next, this is another workhorse set of antibiotics. We have our aminoglycosides, and so there's 3 in this category. Includes amikacin, gentamicin, and tobramycin. All right, so with the aminoglycosides, they are, again, very similar in terms of vancomycin in how they are very narrowly focused on treating kind of one thing, and really one thing only, right? And whereas vancomycin was really good for covering gram positives, we can see here, if my head was not in the way, maybe I can shift out of the way. You have your own PowerPoint slides to look at. This is only good for gram negatives, right? So whereas vancomycin was only good for gram positives, these are only good for gram negatives. No anaerobic coverage, no gram positives, with one notable exception, which I'll mention here in a moment. So what you're going to see here is they have really broad spectrum gram-negative activity. This includes Pseudomonas, right? And again, that's another kind of key one I mentioned before. If something covers MRSA, you probably want to know about it. Something covers C. diff, you probably want to know about it. And something covers Pseudomonas, you probably want to know about it. So this is another group of drugs that is useful for covering Pseudomonas. But it really covers all the gram-negatives here we're going to have available to us. Very good coverage there, even if they're resistant to many other drugs. They tend to have activity still with the aminoglycosides, which is nice. Now, sometimes you can use it for enterococcus, which you're like, well, wait a second, you said Enterococcus is a gram-positive, and that's true, but sometimes we'll use it for what we call gram-positive synergy. And so that's actually where if you have a patient who has something like endocarditis, we can use a gram-positive acting drug like a vancomycin or something and mix it with a gentamicin, for instance, and you actually get better synergy there. So it's used sparingly, but it's something to at least note there. Now, traditionally, we used to use aminoglycosides. We used to dose every 8 hours, but then we kind of got wise to the fact that, well, we don't really need to do that because this is the first sort of concentration-dependent killing drug of note that we're going to be covering here, right? So, and also, even though these are going to be protein synthesis inhibitors, they're still bactericidal. Now, again, why that is, there's probably some postulation out there that says why. I don't know what it is, right? I just know aminoglycosides are going to be bactericidal, right? So this is kind of different from the other protein synthesis inhibitors we've seen before. What do we use this for? I like to use them for things like febrile neutropenia. So if you have someone who has, say, cancer, for instance, and they've received chemotherapy causing them to be neutropenic, or if they have HIV, for instance, that has depleted their white blood cell count, things like that. Or if someone's coming in, say, from the nursing home and they're septic, different things like that, this is going to be a good use for the aminoglycosides. Now, when we're dosing it, you want to be cautious because just like with vancomycin, how we saw that if levels are too high and they're accumulating, that it can lead to renal ototoxicity. Aminoglycosides do the same thing, and in fact, they're probably a little bit more toxic, I would say, than vancomycin is. But sometimes what's tough to do is that when you have a patient who's like coming in for sepsis, for instance, typically they're going to be put on a 3 antibiotic regimen. Typically 1 drug for MRSA, which is most often vancomycin, and then they'll be on 2 drugs to cover for Pseudomonas. And you're like, well, didn't you say not to double cover? And I did, but that's one exception is when you're really worried about Pseudomonas, you have to really kind of broaden your coverage. We actually use 2 drugs at the same time. Talk about that later, but main point being is that frequently one of those drugs is an aminoglycoside. So it's not uncommon to have a patient who is on tobramycin or gentamicin or amikacin plus vancomycin at the same time. And that's where it becomes difficult because if someone has a renal toxicity that occurs, so say for instance they're on vanco and they're on gentamicin for a couple of days and all of a sudden the renal function takes a hit, well, is it because they're they got more hypotensive and they're underperfusing the kidneys? Is it a result of the vancomycin? Is it because of the gentamicin? Or is it a combination? It's really difficult to tell. But by looking at the levels and ensuring they're not getting too high, we can at least reasonably rule out which one of these it could potentially be. Right? So that's why we want to check. In this case here, we're still going to be checking trough levels, but it's not the same reason we're checking trough levels for vancomycin. So I'll illustrate why that is in just a moment here. Again, don't worry so much about the dosing, but again, when we're monitoring, we're checking troughs. But notice here, as opposed to the vancomycin troughs we saw, we wanted to make sure those troughs were above the MIC, right? We want to make sure they're above a certain threshold to make sure they're killing the bacteria. Here, because these are concentration-dependent killers, and we switched from giving Q8 hours dosing to Q24 hours, we're giving a really big dose all up at front, slamming them with a really big dose. So we know those peaks are going to be high. It's impossible that it wouldn't be, right, unless the patient wasn't really getting the drug. So peaks are going to be high. But what we want to do here is check the trough to make sure that they are low. We want to make sure the patient's actually clearing out all of that drug such that the levels are actually undetectable. That's the goal there, such that by the time the patient is going to get that next dose 24 hours later, the drug's out of the system, which is okay for concentration-dependent killers because that has that post-antibiotic effect, right? So even though the levels are negligible, they still are having effects on those bacteria. They're not replicating for that 24-hour period. So we check the trough, make sure the level is undetectable, then redose them, right? So that's kind of what we're doing with the aminoglycosides, and still checking trough levels, but checking to make sure it's gone, as opposed to vancomycin to checking to make sure it's there at a certain level, okay? So those are the big things we're normally going to see with that. Again, if you're checking trough levels, you check it right before the next dose. If you were in an instance where you're using, say, Q8 hour dosing and you want to check a peak and a trough level, you have to make sure you're doing it, at the correct times there, because if the timing's off and the nurse is not documenting that appropriately, sometimes it can lead us to miscalculate what the half-life is, what the volume of distribution is. It's more complicated, so making sure that the levels are done at the right times. All right. So aminoglycoside is great for covering all those gram-negative stuff. Now we're going to switch back over and go to another protein synthesis inhibitor called Linaselid or Zyvox, right? So this is going to be one to where it has very similar coverage to vancomycin. This one's a really good gram-positive killer, specifically MRSA and actually VRE, so vancomycin-resistant enterococcus, or vancomycin-resistant Staph aureus. This is kind of the backup agent that you use if vancomycin is not going to work. You go from vancomycin to Linaselid or Zyvox very frequently. Now, notice here, no gram-negative, no anaerobic coverage you're going to get there. And we typically use it for more like either hospital-associated infections, or if we're worried about really resistant MRSA infections, this is where we're going to go with Zyvox. Now, note here that there is no renal dosing for it, and it's really easy to dose. It's like 600 milligrams Q12. There's an oral version of it that is bioavailable, which you can use, which is kind of one up on vancomycin. Available IV, so it's a really convenient, easy to use drug. So I don't have to worry about monitoring levels like I do for vancomycin. So you say, well, why don't we just use that instead of vancomycin? Well, because you remember we want to reserve some of these drugs for those more really necessary cases, because once we lose Zyvox, you kind of don't have a ton of other options there. And so with Zyvox, you know, it's a cost issue. It's more expensive than vancomycin. And then two, we like to reserve it to make sure we don't get resistance to it, okay? Now, in terms of toxicity, you do want to watch platelet count to make sure they're not going to be getting thrombocytopenic on you. And this is actually a really other interesting one here. So there's a big interaction with anything that affects levels of serotonin. So basically what happens is, if you recall, back when we were talking about the sympathetic nervous system at the end of pharmacodynamics, we recall that the enzymes responsible for metabolizing or catecholamines like epinephrine included the enzyme monoamine oxidase. Well, this drug, you'll actually find some old school antidepressants that work through monoamine oxidase. This drug actually has some minor monoamine oxidase inhibiting effects. So what you end up finding is that if you have this on board with other drugs that increase serotonin levels, and monoamine oxidase also metabolizes serotonin, you're going to find serotonin levels can rise and can lead to a condition called serotonin syndrome, which is not great. I will talk much more about this in depth when we get into behavioral health next semester, but just keep in mind that this has a big interaction with SSRIs, which stands for selective serotonin reuptake inhibitors, pseudoephedrine, which is a drug we'll talk about in ENT as a decongestion. All these things can lead to serotonin syndrome, so just keep that in the back of your mind. You might want to actually avoid it in patients like that, okay? So again, Linaselid is going to be another protein synthesis inhibitor, very easy to use. Avoid tyramine-containing foods. I'll talk more about that next semester, but tyramine-containing foods are precursors. Tyramine itself is a precursor to forming a lot of your catecholamines like serotonin and epinephrine and all of that. And you say, well, what are some tyramine-containing foods? And so don't memorize it for this class necessarily. I'll probably ask you about it next semester, but I always like to talk about tyramine-containing foods as sort of the bougie foods. I'm not sure if you guys are still using that term or not, but those are the kind of fancy highfalutin sort of foods. So things like aged cheeses and aged meats, red wine, those sorts of things. Fava beans, for instance, all of those contain high amounts of tyramine, which can lead to serotonin syndrome if mixed with something that blocks monoamine oxidase. So again, just know that interaction's there. I will get into more detail into it next semester, right? All right. So there's Zyvox. We also have another drug that is kind of similar to Zyvox in terms of activity, mainly being that it's only going to be gram-positives. And this is another one we like to hold back on because of its cost, and also because, again, we like to save our big guns for when everything else has failed. And that's going to be Daptomycin, which has the brand name Cubicin. This one has a unique sort of mechanism to whereas a lot of these other ones we've been talking about so far have been protein synthesis inhibitors. This one's unique that it actually causes bacterial depolarization. So basically, it's kind of like if you ever like watched The Matrix and they cause those EMP grenades to go off and it shuts down all the electronics. This is kind of like that for bacteria, where it basically shocks the cell to depolarize and everything just starts to denature. So it's a very bactericidal effect. It's very good from that standpoint, and it's very good at what it does in terms of killing gram-positive bugs. There are some drawbacks to it. So one thing is that you cannot use it for pneumonias. You're thinking, well, why wouldn't I be able to use it for pneumonia? Does it not penetrate? It's not that. It's actually interesting. It's the surfactant in the lungs, right? Surfactant that keeps your alveoli open and all of that actually will neutralize the daptomycin, actually keeps it from working there. And so because of that, we do not use it for pneumonias. Again, soft tissue infections, sure. Bacteremias, absolutely. Can't use it for pneumonia. Okay. Other things to watch out for is going to be muscle breakdown that can occur, which can manifest as muscle pain initially, but you also want to make sure you're checking those creatine phosphokinase levels, which are evidence of muscle breakdown, CPK levels. Whenever I ask about what CPK means, people started saying California Pizza Kitchen, which had never actually crossed my mind before, but it's creatine phosphokinase. Very important enzyme there that leaches from the muscles when they start to break down. And that can lead to things like rhabdomyolysis, where you get that really severe muscle breakdown that can clog up the kidneys with myoglobin, leading to kidney failure. So not a great complication here. So if you notice that if a patient starts to complain of muscle pain, you want to check the CPK levels to make sure they're not elevating. Otherwise, you may need to actually stop using the drug altogether. Right. All right. So we're going to switch gears a little bit. We talked about our cell wall active drugs. Now we've talked about our protein synthesis inhibitors. Now let's move on to talking about DNA, right? So we can have drugs that can directly affect the DNA of the bacteria to lead to some pretty catastrophic effects on them. And the first stop here is going to be our fluoroquinolones, which is going to include a variety of drugs. The main ones I'll talk about here include things like levofloxacin, ciprofloxacin, or moxifloxacin. Needless to say that if it ends with a ofloxacin or ifloxacin, it's going to be a fluoroquinolone. So pretty easy naming convention there. This one has a pretty cool mechanism of action here, where there's an enzyme in the bacteria called DNA gyrase. And so another name for this might be topoisomerase 2. What does this enzyme do? Well, basically it helps to cause single strand breaks in the DNA to allow it to unwind. Normally your DNA is all wound up quite tightly, and it's difficult for things like DNA polymerase to come in and actually read any of those nucleotides. So what does this enzyme do? Well, it causes strand breaks to occur that allows it to unwind and then can reseal those strands back together. What would happen if I inhibited this process? Well, basically, if I did that, it would cause this DNA damage to occur because it couldn't unwind and rewind appropriately, and leading to more strand breaks. And eventually, there's so much damage done to the DNA that the cell just says, let's call it quits and let's commit apoptosis, right? So that's programmed cell suicide, right? So that's what's going to happen here. That's roughly what we're seeing with the fluoroquinolones. They inhibit that process here. Now, fluoroquinolones, pretty good drugs. They have a wide variety of use. They're going to get atypical bugs. They'll get some gram negatives. They'll get some gram positives. No MRSA, but these actually do cover Pseudomonas. And I'll go over some of the more fine points on the coverage here in just a moment. But they are useful for all sorts of things. We can use them for UTIs. One note accessible being moxifloxacin, which I'll mention here in a moment. You can use them for community-acquired pneumonias and a lot of upper respiratory tract stuff. You can use it for skin and soft tissue infections. It seems like you can use it for everything. This is kind of similar in terms of like the tetracyclines I mentioned before. It just has really wide coverage, but there are some downsides to it. One of which being resistance. It's really easy to overprescribe things like Levaquin and Cipro, and it leads to such overuse that there's a ton of resistance. And in fact, we're not able to use them for a lot of infections because patients are coming in with community-acquired stuff that is resistant to these, or they've been on several courses of antibiotics in the past and they're just resistant, right? So there's a lot of interactions here too. So similar to the tetracyclines, these also chelate certain ions, which means if you have calcium-containing antacids or multivitamins or dairy or iron or anything like that, they'll chelate to the drug and prevent it from being absorbed. These also lead to QTC prolongation. So this is another thing we saw with the macrolides that is now shared by the fluoroquinolones, right? So you can start to see a little bit of, the Venn diagrams for some of these things are starting to overlap with one another, where you can start to remember, okay, which drugs do I have to worry about causing QTC prolongation? Okay, I want to know the fluoroquinolones and the macrolides. Okay, which ones are going to chelate to calcium and iron? Okay, I know the tetracyclines and the fluoroquinolones. So again, you can start to organize these things in your mind in terms of what are the overlaps, what are the things that are unique that separate them out. You can start to organize that stuff, right? Fluoroquinolones are also not great for elderly patients, mainly because they can cause some CNS toxicity. So sometimes with elderly patients, you don't know if it's, say you have, your grandma or grandpa's coming from the nursing home. They just got an infection, maybe start off as a UTI, maybe now it's spreading, and you put them in the hospital and say it's going to be evening time, and they just start wigging out. They just start getting really aggressive. Maybe they're very anxious. Maybe they get even violent in some cases. Oftentimes, it's very difficult to discern what's causing altered mental status in an elderly patient. Is it the fact that they're in an unfamiliar environment and they're sundowning? Is it because of the infection leading to the altered mental status? Is it as a result of the medications we're giving them? And you always got to keep that in your differential. And elderlies with new onset altered mental status, what medications are they on? What's been started recently? What's changed? And that may clue you in, okay? This can also have some warfarin interactions similar to the penicillins, which can lead to some bleeding propensity, so just be cautious with that as well if they're on anticoagulants like warfarin. So as I mentioned, with overuse, you're going to see a lot of resistance there. There also is going to be some collateral damage in terms of the fact that, you know, not only are you going to be getting all of the pathogenic bacteria, if your patient has pneumonia, for instance, you can get rid of that, but also you're going to be getting rid of a lot of that healthy gut flora. Anything covering a lot of anaerobes is going to get a lot of that gut flora, and that can predispose you to C. diff. So this is another common one that can lead to C. difficile infections, which you may need to treat with additional medications, right? So anyway, so starting with the second generation fluoroquinolones, and you may be asking, what about the first generation? Those are still out there. They just are not used systemically as common. So I'll talk about that in the ENT section. Ofloxacin is probably one of the big first generation ones you'll run into. But starting second generation, we'll see with Cipro, you know, it has pretty good gram-negative and atypical coverage. It's kind of plus or minus on Pseudomonas, so you won't see Cipro used as commonly for pseudomonal infections, systemically speaking, that is. I'll talk about some exceptions to that in later sections there. But you can see here that it's also going to be renally dosed, so you got to make sure you're watching for renal function. That's another big thing. A lot of people will just go ahead and give them a dose of Cipro, let them take it for 7-10 days, and they don't look at the renal function and realize, oh wow, the patient's having toxicity from that. So you gotta check out for that. It's not like the macrolides where you don't have to worry about renal function. These ones you certainly do. And then bumping up to the third generation here, you see that you get better gram-positive coverage with something like levofloxacin. Now you see that levo, and you should be thinking in your head, oh, that sounds like an enantiomer. And it is. It's actually the left-handed version of ofloxacin. So from ofloxacin, you can pull out levofloxacin there. And so you can see it has even better Pseudomonas coverage here. So this is one that you'll frequently see being used as double coverage for Pseudomonas. So for instance, I mentioned you'd use vancomycin for MRSA. And if you're worried about Pseudomonas, you could use an amino glycoside plus a fluoroquinolone, for instance. Or you can use an amino glycoside plus an anti-pseudomonal penicillin or cephalosporin, or something like that. So those are the cases sometimes where we do double cover. Now you do see third generation fluoroquinolones used all the time for community-acquired pneumonias because it covers two of the big bugs there. It covers strep pneumo, which may be resistant to a lot of things like penicillin. And it does cover things like mycoplasma and other atypical pathogens, whether it be, you know, Legionella and some other ones there, Chlamydia, for instance. So good coverage from that standpoint, but again, overused pretty frequently. And again, you got to watch the renal function there. And Moxifloxacin is kind of interesting because this one I mentioned does not have great Pseudomonas coverage here, so you wouldn't use it for that purpose necessarily. But another thing that is interesting is that this one you cannot use for for urinary tract infections. And you're like, well, why not? And that's because as opposed to where the other fluoroquinolones were renally eliminated and had to be renally dosed, Moxifloxacin is kind of the outlier there. Here it's actually going to be entirely hepatically eliminated, and so there's no renal elimination. And so if the drug never gets filtered and makes it to the kidneys, you can't really treat any infections that are there, right? So this is why you would not be able to use it for that purpose. Could you still use it for some pneumonias? Absolutely. It's used all the time, but you would not use it for urinary tract infections. So I talked about a lot of the side effects already. Some other things to think about include things like photosensitivity. Either have them stay out of the sun or make sure they're using high SPF sunblock. Talked about the renal elimination for Cipro and for Levaquin, but not for Moxifloxacin or Avelox. I mentioned the QT prolongation. Another kind of unique one here is actually this tendinitis and the risk for tendon rupture, specifically the Achilles tendon tends to be more affected than some of the other ones. So this is more of a concern, especially in younger patients. So we typically see this more often in children who are less than 18 years of age. And so you want to be cautious. I would not say this is an absolute contraindication to using fluoroquinolones in children, but if you have another option available, I would definitely go with that in those instances, right? You can see some peripheral neuropathies, which tend to affect, like, you know, the hands and the feet most frequently. And I talked about the CNS toxicity, which is more prominent in elderly patients. All right. Up next, we have Clindamycin. This one is kind of in a category of its own, kind of a unique sort of antibiotic here. This one's pretty cool in its coverage because it's mainly going to cover anaerobes and gram-positives. It does not cover any gram-negative, so it's kind of an oddball in terms of its coverage there. So we can use it for things like MRSA, really good for like skin and soft tissue infections. Really good for anaerobic infections, so you could use it, for instance, if you had a patient who had like an aspiration pneumonia and you were worried about anaerobes, you could use it for that, for instance, but no gram-negative coverage. So if you had a patient who you're worried about having a gram-negative, that's on your differential in addition to gram-positive, you would need another drug in order to help cover that. So kind of one thing to note there. Now, where do we use this? Well, it's actually kind of useful for things like toxin-mediated diseases. So imagine you had someone who had something like toxic shock syndrome. Clindamycin is cool because it can actually bind to some of the exotoxins that those bugs can release that lead to that shock-like syndrome there. So sometimes you'll see that being used for that purpose specifically, not necessary to treat the pathologic bacteria there. Used a lot for skin and soft tissue infections, things like osteomyelitis, sometimes for surgical prophylaxis they cannot receive a beta-lactam, and as I mentioned, for intra-abdominal infections, we can see this used in combination with something that covers gram-negatives. That way you got the anaerobic coverage, and then you use something else for the gram-negative coverage. So, you know, I don't often propose to use 2 drugs when one will do, but if this is your only option, then that could be used. Now, in terms of side effects here, you know, you want to watch the CBC to make sure you're not developing any sort of blood dyscrasias like neutropenia, thrombocytopenia. This is another big one. This is probably the biggest one that causes C. diff. So if you had to think about which drug, which antibiotic is most likely to give you C. diff, clindamycin is commonly the one you think of because of its really potent anaerobic coverage. It will wipe out a lot of that gut flora. So that's a big one. And that can lead to things like pseudomembranous colitis and a lot of inflammation, a lot of issues with the GI tract. So make sure to watch out for that. All right, up next, we have, now we're kind of getting into the hodgepodge sort of variety of antibiotics here. But next off, we have sulfamethoxazole and trimethoprim. This is a combo drug that is frequently given together. So common brand names include things like Septra and Bactrim. Very common use for a lot of UTIs, skin and soft tissue infections, and we also use this for many opportunistic infections in patients who have immunocompromisation, HIV, cancer, etc. So this one's kind of cool because it works through 2 synergistic mechanisms here. So you can see where we're using 2 different drugs to work on the same sort of pathway. So whereas something like the fluoroquinolones worked specifically on working on that DNA gyrase, that topoisomerase enzyme, now instead we're working on the DNA, but we're preventing it from forming new nucleotides, right? So we're actually preventing it from forming the DNA in the first place. So if you can't form the DNA, new DNA, then you can't replicate, right? So that's how it's kind of working here. So what we're going to see here is that sulfamethoxazole is going to be inhibiting that conversion of PABA to dihydrofolic acid. So basically it's preventing the bacterial cell from utilizing folic acid in the first place. And then trimethoprim is inhibiting the further conversion of DHF, dihydrofolate, over into tetrahydrofolate or tetrahydrofolic acid. So kind of working on 2 steps of the same process here to prevent production of new nucleotides. So in terms of coverage, no anaerobic coverage, but pretty good gram-negative, pretty good gram-positive coverage. So it does get MRSA, so we could use it for skin and soft tissue infections, but doesn't cover enterococci. That's one notable hole in coverage there. But what's interesting here is this coverage pretty wide-ranging for gram-negative aerobes. So things like Burkholderia cepacia and Stenotrophomonas multifilia, things like that, where most healthy immunocompetent patients are not going to get these bugs, but those have immunocompromisation. So for instance, if I have a patient with cystic fibrosis, where basically they have such thick, tenacious secretions that they can't clear all the junk out of their lungs, they oftentimes in later stage of their disease can get colonized with bacteria like Burkholderia cepacia that most immunocompetent patients would never get. And so that's where things like Bactrim can be really helpful there. And as I mentioned, for opportunistic infections, things like pneumocystis carinii, nocardia, toxoplasma, can all be covered here. Again, am I going to ask you specifically what does Bactrim cover out of this list? Probably not, but I do want you to know the mechanism, side effects, drug interactions, all that good stuff, things that you should be able to pull out of this this lecture here. Okay. Anyway, so we use it for a wide range of things, UTIs, respiratory tract infections. We can also use it for some GI infections, so things like traveler's diarrhea can be useful here. Shigella will have some coverage for, so very handy from a lot of GI standpoints additionally. Even though it doesn't cover gram or anaerobic bugs necessarily, it can get some of these more pathogenic ones like E. coli and Shigella, for instance. So what are some downsides to Bactrim? Certainly the GI effects, like many of the other drugs we already saw here, but this has a higher risk for causing Stevens-Johnson's and toxic epidermal necrolysis. We mentioned it briefly before with the penicillins, and that's a fairly low risk, but certainly with Bactrim, this is where we more worry about it with this one. So if you notice any new rashes or mucous membrane irritation, blisters, anything like that, really want to have the patient be worried about that and stop taking the drug and coming into like the ER, for instance, to make sure they can rule that out. Now, I said that, a lot of the antibiotics are specific for bacterial targets, and that is true to a large degree, but we can see some bleed over that may not be perfect specificity, and so you can actually see that if Bactrim can affect the bacterial utilization of folic acid, that it can do that a little bit to us as well. And so that's why you can see some blood dyscrasias, things like thrombocytopenia, agranulocytosis, etc., because it can affect folic acid utilization for those cells. Okay. Other things to watch out for is it can have a drug interaction where it can increase levels of certain drugs, things like digoxin, phenytoin, and rifampin. We'll get into these ones later. Just know there are some kinetic interactions here. You want to be really cautious with other drugs that actually can affect folic acid as well. So things like methotrexate, which again I'll mention in a later set of lectures when we get to the cancer section later on there. And again, this is actually a really big one I want you to note here, is it can actually increase INR for patients who are on warfarin, right? So I mentioned warfarin is an anticoagulant. It affects PT-INR significantly. So by inhibiting this enzyme CYP2C9, you can boost up levels of warfarin, and that will then boost up the INR, making your patient more likely to bleed. I've seen some cases of patients who have been, therapeutic INRs between like 2 and 3. I've seen some patients who were started on a dose of Bactrim for like a UTI. No one took into account the fact that they were on warfarin at the same time, and then before you knew it, the patient's INR was like 6 or 7, and they're having active bleeding in the GI tract. All right, so up next we have Metronidazole or Flagella. This one is causing a little bit of a different mechanism here, where it's going to be interacting with the bacterial DNA and actually causes it to lose some of that helical structure. It leads to some more strand breakage, and as I mentioned, the more damage you cause to the DNA, eventually that bacterial cell just calls it quits and commits apoptosis, right? Metronidazole is very specific in what it works on. It has really good anaerobic coverage, both of the gram-positive and gram-negative variety. It also treats some parasites. That's kind of a unique thing we've not seen so far. Now, this is actually the old school drug of choice for Clostridium difficile. Now, as with vancomycin, you could only give oral vancomycin to treat C. diff. This is kind of interesting because you can give IV or PO metronidazole to treat C. diff. And so, as I mentioned, its drug of choice is kind of going by the wayside a little bit in favor for vancomycin, but for children, you'll still see it listed as your first line. One thing to note with that, we will use it frequently in combination with other drugs for intra-abdominal infections. So, for instance, for some patients who have appendicitis, I've seen the physician to order something like ceftriaxone to get good gram-positive, gram-negative coverage, and then they put metronidazole for the anaerobes. So again, using combination therapy to widen out your coverage when you're not sure what might be causing an infection. And then some STIs can be treated here as well, as you'll see due to the anti-parasitic effect that it has. Now, in terms of side effects, one really unique one you're going to see with metronidazole is what we call a disulfiram-like reaction with ethanol. What does that mean? Well, disulfiram is another drug that actually used to be used, sometimes still is used, for patients with substance use, alcohol use disorders. Okay, what does it do? Well, basically, when you are metabolizing alcohol, there's a set of different enzymes that are used, and so there's one step where it'll take ethanol and it will undergo alcohol dehydrogenase. That's the enzyme, and it'll break ethanol down into something called acetaldehyde. And then normally you have another enzyme called acetaldehyde dehydrogenase that will then further break that down into further metabolites and eventually converts it over to CO2 and water, right? So what happens though is that this drug can actually come along, Flagella, and this other drug, disulfiram, can inhibit that second step, and it inhibits that acetaldehyde dehydrogenase and prevents it from being broken down. You say, okay, what does that matter? Well, acetaldehyde is a really irritating molecule. It actually causes a lot of nausea, vomiting. It causes a lot of vasodilation, so it causes flushing. Patients feel really hot. They just feel miserable. And so the idea was if you're taking disulfiram and you have a drink of alcohol, you're going to feel so miserable that you won't do it next time, and so it deters you from using the ethanol. Obviously compliance with that drug is not great, so you still need to know about it for Flagella though, because you can have cases where you can have patients who are drinking alcohol along with this, and then can actually cause some significant disulfiram reactions. Now, this is actually the same thing. If you've ever heard of the term, I've heard it used before, called the Asian flush. That's actually a similar thing, because you can find some patients who are of Asian descent who don't drink alcohol because they have a genetic relative lack of acetaldehyde dehydrogenase that leads them to have this same reaction. So for instance, I know my medical director when I was in fellowship, Dr. Kunisaki, was of Japanese descent, and guess what? He would never drink alcohol because if he even got a whiff of the stuff, his whole face would start to get red, start sweating. It was miserable for him. So again, sometimes patients can have a predisposition to this, or sometimes drugs can actually initiate this. I actually had a pharmacist friend, which is kind of interesting. He was a pharmacist. His wife was also a pharmacist, and I guess she was suffering from rosacea, and this is something that you can use metronidazole for. And she's using topical metronidazole, so you're using it on the face. And I think they're out at Olive Garden or something, and she ended up drinking a glass of red wine, not thinking about the fact that she had that metronidazole on her face. So even though she didn't take it orally, even though it wasn't a systemic drug, all of a sudden her face starts to get really red. She starts to get sweating profusely. Everyone thinks she's having a heart attack, right? And so all the waiters and waitresses are like, is she okay? And then, he had to be like, oh yeah, we totally forgot about this. So even healthcare providers, even pharmacists can be making, kind of dumb mistakes with medications, which is why you gotta be really cognizant of this stuff and really think about it when you're prescribing. All right, some other random, antibiotics we have here. We have polymyxin B and E. Now, you'll frequently find polymyxin used more so in topical products. This is mainly because these are really nasty from a toxicity standpoint, so we don't like to use them systemically very often, but these have a very specific set of coverage, mainly gram-negative, so you can kind of think about them in terms of coverage like you would an aminoglycoside. Basically, what these can do is can actually disrupt the cell membrane, leading to bactericidal effect by affecting things like magnesium and calcium. And so very good at killing those gram-negatives there, but it also tends to be not quite as specific for the bacterial cells and can affect us as well. Now, we're going to see that there's not a ton of resistance to these drugs because they aren't used too frequently because they're so toxic. But as time goes on, as we get more and more resistant gram-negative bacteria, eventually this is the only thing we have. And so we have to take the good with the bad in order to make sure, would I rather have a patient who has nephrotoxicity and is alive, or someone who has good kidney function but has now gone down because they're dead? So that's kind of the double-edged sword you're kind of having to deal with there. And so it may be something you see. Not only does it cause nephrotoxicity, it can also cause CNS toxicity, neuromuscular issues. So if they are, on the ventilator and they're paralyzed, this can affect issues with their paralyzation. We'll talk about that later, but just know there's a pretty nasty set of drugs. When used topically, they're totally fine because they don't really have any bioavailability. So that's why you can use it in things like Neosporin, no problem. But when you give it IV, that things become more of an issue. So I've been going on now for close to an hour and 20 minutes. I didn't have any interaction with you guys, so I'm assuming this is about the amount of content I would have covered in a typical time frame. So I think I'm going to cut it off here. Seems like a good cutoff point before I get into the antifungals, and then from there we'll talk about our ENT and our ophtho stuff. So again, I apologize for having to do this pre-recorded. I always intended to do these all live, but unfortunately life happens, and so I was not able to do that due to the family circumstances. But I really encourage you, if you have questions, put them on the sticky board, put them, email them to me, and I'll talk about them at the beginning of the next class. Let me know, because if you don't ask it, and the only person you're hurting is yourself, right? Yeah, so without anything else, you guys have a great weekend, and I will see you next time. Thanks a lot.